Hello, friends. So I'll be talking on this topic as a primer for the journal presentation that's going to happen subsequently. Delirium in ICU. So I'll be only touching very briefly on the causes and few aspects of delirium, not the whole topic. So there's a whole lot of material on delirium. So with regards to the treatment, I won't be touching about the treatment of delirium because there are a lot of trials with regards to various molecules that are used in delirium. I'll do it as a separate talk. So this is just a primer for the journal presentation that's going to be happening. So wish to acknowledge my colleague, Dr. Pratibha, who helped me developing this consent. So, when we talk about definition of delirium, delirium can be a question for all the trainees. So, it has around 5 to 6 components. So, these are the key components in the definition that possibly one should keep in mind. So, there'll be disorganized thought process or the disorganized thinking that will be there in the patients with delirium. So, the key aspect of delirium is there is a fluctuation in the mental status and there will be acute change in the conscious level of the patient. So that is the key aspect of delirium. So the conscious state or the mental status, what is at one point of time will not be the same maybe in next 1 minute or few minutes of the time. So there will be a constant change and fluctuation in the conscious level. So fluctuating conscious state is the key hallmark of delirium, disorganized thinking, and there's a disturbance of the cognitive. So they wouldn't, the cognitive impairment will be there, and there will be disruption of their mental capabilities and inattention. So they cannot pay attention to any aspect that you may be communicating or any focal aspect, they won't be having attention. And there'll be a huge mood change. So I'm sure most of the listeners would be aware there are different types of delirium, hyperactive, and mixed. So there can be intense sadness or there can be in a elated mood. So their mood fluctuation is another important component of delirium. And the most important in ICU, which we tend to witness, is psychomotor agitation. So these are the 6 components which constitute the definition of delirium. So the key hallmark is the fluctuating change in the mental status with disorganized thinking, with a cognitive impairment, inattention, and a mood change with psychomotor agitation. So these are the key components or ingredients which define delirium. So you can put all these components in any format will constitute the definition of delirium. So when you look at pathophysiology of delirium, there is a lot of sort of a evolution that has happened in the understanding of delirium. So there are two important pathognomonic what is currently understood. So one is due to direct insult to the brain, which act as a trigger to the delirium. So it can be traumatic brain injury or any sort of a insult to the brain can act as a trigger for delirium. So it can be an organic injury to the brain, like there can be a stroke or intracranial hemorrhage. All these are some of the triggers or hypoxemia. So if and there is a systemic hypoxemia or a brain hypoxemia is touted to be one of the important trigger for delirium or hypotension. So these two are very important in ICU as to why delirium is common in ICU because ICU patients are someone where all these events tend to occur hypoxemia, hypotension, and hypercapnia. So, when you look into the evolution of the literature, most of the pointers are towards these insults, which act as an important trigger. Why delirium is so common in ICU is because ICU patients are the ones who would be troubled with hypotension, hypoxemia, hypercapnia, and these act as an important trigger because when there is a systemic hypoxemia, some amount of brain hypoxemia also can be there, and they act as triggers for delirium. And I'll tell you what are the molecular changes that happens in the brain. So the one aspect of delirium is the direct injury to the brain, and there is something called aberrant stress response. And this aberrant stress response is due to any of the conditions that are present in ICU. It can be infection or post-surgical patients or anxiety. All these aberrant stress response is known to cause some sort of a cytokine storm within the body. And this cytokine storm is shown to cause limbic hypothalamic pituitary axis dysfunction. So limbic hypothalamic pituitary adrenal axis dysfunction. And this dysfunction leads to sustained increase in the cortisol. So this has been found to be one of the important sort of a trigger for the molecular changes that happen in the brain. So limbic, hypothalamic, pituitary adrenal axis dysfunction leading to sustained increase in the cortisol leads to a lot of chemical changes within the brain, which I'll show you. So there's a beautiful review article that come in Nature, which elucidates in a very elaborate way all the molecular changes, but I have tried to simplify it and try to give you the salient aspects as to what are the molecular changes that happen in the brain. So I request all the listeners to read this nice review article that come in Nature. So what they have shown is all this, the aberrant response leading to sustained increase in cortisol leads to a lot of chemical changes in different areas of the brain. So the main areas of the brain which has been looked at is the basofrontal region, which is where there is aberration of the acetylcholine and the GABA molecules. And then there is this tuberomammillary nucleus, so where there is aberration of the histamine molecule. So there are a lot of changes of these chemical neurotransmitters within the brain, which act as a trigger for delirium. And these are the areas which have been identified. Then you have this locus coeruleus, which have where there is which is responsible for aberration in the norepinephrine or noradrenaline in the brain, and there is pedunculopontine tegmentum where there is acetylcholine disturbance and laterodorsal tegmental nucleus. So these are the areas of the brain where there has been disruption of these chemical neurotransmitters which act as a trigger for delirium. So this is a nice article which has looked into these areas where this neurotransmitter imbalance occurs, and they have been touted as the areas for which trigger for the delirium. And so this is another important pictorial representation that's come out in this journal. So what it has clearly shown is uh, when you read this review article, it clearly mentions there is a lot of hypoxic ischemic changes within the at the neuronal level, which leads to delirium. So what they have shown is the glucose transporter, which is responsible for the movement of the glucose from the capillary to the neurons. So there is a disruption of this. So this glucose is transported from the capillary to the neurons by glucose transporter 3, and this leads to the production of pyruvate. And this pyruvate, as most of listeners would know, will help in mitochondria to produce energy within the cells, which is ATP. So this pathway gets disrupted because there is no effective transport of glucose by the glucose transporter, and pyruvate leading to ATP gets disrupted, and there is more production of lactate, so which leads to anaerobic metabolism. So this is happening at the neuronal level. So more of lactate production within the neurons is touted as one of the important reasons for delirium, along with all those other chemical changes with acetylcholine or norepinephrine or GABA, all those other in the previous slide you saw, they also add on to this. So more of lactate production at the neuronal level has been touted, and they have described something as um, so there is astrocyte neuron lactate sort of a shuttle that happens. So there is lot of movement of lactate that happens from the astrocytes to the neurons, which has been uh, put as a astrocyte neuron lactate shuttle that happens, and that also leads to increased production of lactate within the neuron. So in simplistically, you can remember as there is more lactate production at the neuronal level due to hypoxemia or due to impaired transport of glucose, and there is lot of shuttling of lactate that happens from the astrocytes to the healthy neurons, which also leads. So astrocyte also is one of the uh, cells that get affected that leads to increased lactate production and pushes this lactate into the healthy neurons, which leads to delirium. So that is the simplistic understanding that you can gain by reading all these advances that have happened in trying to understand the pathophysiology of delirium. So that's about the pathophysiology. Simplistically, you can remember as lactate production increases. There is a lot of neurotransmitter disturbance that happens at all those areas that I mentioned, locus coeruleus or basal frontal or mammillary tegmentum, so on and so forth. And so those are the dominant chemical changes that happen. So when we look at the incidence of delirium, it's around 16 to 89%, so which is astoundingly high. So this is the incidence of delirium in patients who are within the hospital. And 45% of the delirium tends to happen in the post-anesthetic setting, and 50% of delirium happens in the post-surgical setting of some nature. So this is something which commonly happens in a hospital setting. So it is quite intuitive for us to understand as to why delirium occurs commonly in this setting. But the highest delirium is in ventilated patients. 80% of the ventilated patients are at a risk of delirium. So when we talk about causes of delirium, we can categorize into pre-morbid risk factors and the morbidity risk factors and in the recovery phase risk factors. Any conditions in ICU constitutes the risk for delirium. So when we talk about pre-morbid risk factors, just simplistically, I put it in a pictorial format. Pre-existing dementia or someone who has had delirium before are at a much higher risk of developing delirium. And someone who is visually impaired or who is hard of hearing. Very commonly, we see elderly patients in ICU. Many we would see who may be having hard of hearing, and that puts them at a higher risk of delirium. Frailty is another important risk for delirium or malnutrition. If someone has had a malnutrition, frailty, that constitutes risk for delirium. And of course, we know ethanol, alcohol dependence is a very important risk for delirium or advanced age or comorbidity burden is more. If there is more number of comorbidities, that puts them at a higher risk for delirium. And someone who is taking psychotropic drugs of some nature or antidepressants or antipsychotics, so all these or sedative drugs, all these constitutes risk for delirium. So these are pre-morbid. Someone who is on all these, who's having frailty, malnutrition, who's had a history of delirium, ethanol dependence, advanced stage. Advanced stage is very commonly we see in ICU or more comorbidities. All these constitute pre-morbid risk for delirium. When you talk about clinical risk for delirium, any clinical condition that we see in ICU constitutes the risk for delirium. So I've just put again in pictorial format. So any neurological condition, subdural hemorrhage, extradural hemorrhage, seizure, or heart failure, or MI, or post-surgical patients, ethanol, or pulmonary embolism, venous thromboembolism, any GI bleeds, pancreatitis, acute kidney injury, even transfusion. So any of the ICU conditions, you can just write whatever conditions you see in ICU, all of them constitutes risk for delirium. But these are certain things which are specifically mentioned. And anyone with an endocrine hypothyroidism, hyperthyroidism, someone with sepsis, ARDS, liver dysfunction, cancer, any ICU conditions, any condition that necessitates the patient to come to ICU are to be considered as a risk for delirium. And electrolyte imbalance is often seen in ICU. Surgery, any post-surgical case, and more specifically cardiovascular surgery, major abdominal surgery, or anyone who has undergone emergency surgery, or major orthopedic joint surgeries, all these constitute risk for delirium. So you don't have to memorize this. Any clinical condition that you deal with in your ICU constitutes risk for delirium. And someone who is ventilated for more than 96 hours is an important risk for delirium. So for all the trainees, when they ask what are the, when you delirium can come as a short note. So if you have to write the causes, put the causes into three main categories: pre-morbid cause and the clinical conditions that they have come to ICU for, and the post recovery phase sort of a risk factor. So post-admission factors, again, you can categorize into the surgical. So someone who has pain, where pain is not controlled adequately, or immobility of the patient. And this is very specific to post-surgical. If post-surgical setting, patient is in a lot of pain, not able to move, has secondary infections, someone who has ileus or electrolyte abnormalities constitutes important risk for delirium in the recovery phase. In ICU, the use of steroids and opioids in ICU does put them at a risk for delirium. And sleep disturbance is very common in ICU, and day-night orientation is lost in ICU. All these constitute risk for delirium or lack of communication with the patient by the nursing team, by the doctors, by the family, all constitutes risk for delirium or over sedation, deep sedation due to a lot of use of benzodiazepines puts them at a high risk for delirium. So these are some of the risks specific to ICU. These are risks specific to surgery. These are the risks specific to ICU. And putting restraints to the patient in ICU also puts them at a risk for delirium. So these are some of the overall causes of delirium specific to surgical causes, specific to ICU, and some of the causes which are pre-morbid related. So that's how you can categorize when you look at the causes for delirium. So there are three subtypes of delirium. Most of you would have heard this. Hyperactive delirium, which we commonly see in ICU, evidently is actually less. 23% constitutes hyperactive. Hypoactive is actually more. 24.5 to 43% constitute. It's always challenging to pick up hypoactive delirium in ICU because it's easy to recognize hyperactive. But the more commoner ones is the mixed delirium. 52.5% constitutes mixed type of delirium. So I'll just briefly mention about the scoring tools that are available to recognize and diagnose delirium. So there are five sort of validated tools that are there. The most common ones we use is CAM-ICU. So CAM-ICU is confusion assessment method in ICU, which is a validated tool, and I think that is the easiest tool to use, and it has a good sensitivity, which I will show you. And there is intensive care delirium screening checklist. So this is ICD-SC, which is intensive care delirium screening checklist. The third one is delirium detection score. The fourth one is nursing delirium screening scale. These are all the validated tools. And the fourth one is Nilon and Champagne confusion scale. So the easiest one for all the listeners is you can mention these if they ask you in the exam, all these five scoring tools. But the one which is practically followed is the CAM ICU or the intensive care delirium screening checklist. These are the more widely used. CAM ICU is the simplest one that you could use. So just briefly mention about the components of CAM ICU. Very easy. When there is acute onset of mental status change, which I mentioned is the key hallmark. Change in the mental status, which should be fluctuating in nature with time, along with inattention. So if these two are present, then you see if these two are coupled with disorganized thinking or if there is altered levels of consciousness. If these three are present, you call it as delirium. It's a very simplistic tool and it is validated. There's a study which says the sensitivity is very good at 93% and specificity is 89%. So it has a good sensitivity and better specificity than the other score, intensive care delirium screening checklist. This is much better. So very simple. Acute change in mental status with inattention, with disorganized thinking or altered level of consciousness is equal to delirium. So the intensive care delirium screening checklist, which is the second common use. So these are the components. So the components, remember the definition. Definition had six components. It had disorganized thinking, fluctuating level of consciousness, and you had cognitive impairment, psychomotor agitation, mood fluctuation. So all these constitutes part of this. If the score is more than 4, you call it as delirium. But when you look at sensitivity, this is validated in this study from Canada. Sensitivity is very good, but specificity is low. It is at 64%. So if you look at CAM ICU, sensitivity was 93% and specificity was 89%. Here specificity is little poor. So the last slide, I'll just talk very briefly on delirium bundle that could be adopted in ICU for assessing and approaching the case of delirium. As I said, I wouldn't talk about treatment. Treatment, I will talk about all the trials in the uh, another video. So here I'll just talk about delirium bundle. It goes with an acronym ABCDF. A stands for assessment of pain and prevention and pain management. Assessment of pain, prevention of pain, and management of pain goes a long way in preventing delirium. And in patients, as I said, more than 96 hours, ventilated patients are at the highest risk for delirium. So we should not keep them deeply sedated. So we have to do spontaneous awaking and breathing trials. So we have to give SPT trials and we should awaken. We should give sedation-free intervals in patients who are intubated and mechanical ventilated to mitigate and minimize the risk of delirium. And choice of sedation and analgesia is important because it's very clearly shown use of excessive benzodiazepines significantly increases the risk of delirium. So try to use non-benzodiazepine sedatives like maybe opioids or dexmedetomidine, so on and so forth. And using it minimally reduces the risk of delirium. And assessing delirium in ICU using the CAM ICU or the other tools and trying to recognize delirium early on and treating it goes a long way in reducing the morbidity. And early mobilization is an important tool to minimize the risk of delirium. And engaging the family and empowering the family and involving them in the care management of these patients go a long way in preventing and addressing the morbidity aspect of delirium. So that's the primer for the journal that will be presented on haloperidol use, because there are a lot of trials. Just to give a brief, there are a lot of trials using various drugs to treat delirium. Not many trials have shown to be effective with regards to any magic agent which has shown to significantly treat or reduce the morbidity aspect of delirium. So the current trial that will be discussed is on the role of haloperidol, which is a positive trial which has shown improved outcomes. So thanks one and all. So I request all of you to submit your valuable work to our Journal of Acute Care, which comes out every 3 to 4 months. So you can visit my website www.drpradeeprangappa.com to rehear to this lecture. So thank you one and all.